Alors, attends, zoom. Voilà. Alors, partage d'écran. Ah, paraît-il qu'il y a un autre participant qui partage son écran. Alors, attends. Vous ne pouvez pas partager le partage d'écran pendant qu'un autre participant partage son écran. Donc là, j'y arrive pas.
Tu n'arrives pas?
Non, parce qu'il y a quelqu'un d'autre qui partage déjà son écran.
Então, je vais voir ce que je peux faire. Je vais parler avec... Oi, Eduardo, tudo bem?
Ei, João, tranquilo?
Oi. Here's a small problem to share screen. We're just going to talk to somebody. Ça va toujours pas, Sébastien?
Non, il y a marqué que quelqu'un partage son écran et donc je ne peux pas partager le mien.
Oui.
Non, il y a quelqu'un qui partage son écran, mais alors je ne vois pas qui.
Pas moi de toute façon.
Non, caméra.
Oi, Kelly, não está conseguindo.
Ah, ça y est. C'est bon, je crois.
Ok. Oui, voilà, elle m'a dit qu'elle était en train de le faire. Mais donc, écoute, les gens sont arrivés. Je vais commencer à parler en anglais, ok, Sébastien?
D'accord, pas de souci. Alors,
Eduardo,
attends, oui. Ça va
welcome.
peut-être. Il faut que je quitte et que je revienne parce qu'il faut que je raccroche parce qu'il faut que je reconfigure mon Zoom. Mais j'arrive.
Ok. Oi,
Boa
Eduardo.
noite, João.
Oi, Silvânia. Oi, tudo bem? Ele já vai voltar,
Tudo.
é porque ela estava compartilhando
Eu vi.
ao mesmo tempo, daí ela não conseguia. Agora deu certo.
Uhum. Tá.
Já começa daí. Tudo bem? Tudo bem, vocês?
Tranquilo.
Tudo ótimo.
Deixa eu pôr meu óculos aqui, porque tem que ler umas coisinhas e eu não consigo. Já tô assim. É.
Eu também.
Acontece
Só
para todo
Eduardo
mundo.
que tem olhos
É só questão de tempo.
Acho que só Eduardo.
É, mas não vai demorar.
Quando eu opero, eu já estou usando.
Então.
Já entra.
Você só vai tentar ali, se está tudo certo, daí já apresento vocês. Meia-noite. Oui, c'est parfait. Ouais, je vois parfaitement.
Do you see my screen?
Yes, perfectly, yeah.
Okay, thank you. Great.
So I'm going to introduce you the other speakers who are with us now. And then after that, I'm going to say some message and then we start, okay, Sebastian?
Okay, wonderful.
So I would like to introduce you Professor Eduardo Ramos, who's one of the person I was talking to you beforehand. He worked at the Mayo Clinic, and here in Curitiba, he develops a very fine work on all kinds of hepatic and pancreatic neoplasms.
Hi, how are you?
And at the same time, Professor Silvania Pimentel, also a former surgical fellow at Mayo Clinic, and also performs plenty of cancers and trauma as well at a hospital called HT, Universitarian Place. Okay.
Hello.
Nice to have you here.
Hi.
So we are going to start formally. So good evening, everybody. Dr. João Nicoluzzi. And this is the HPB 21, an online course about hepatic and pancreatic surgery. I'd like to make some thanks to everybody who's been attending the course since the very beginning, into some societies who are supporting us, such as the Brazilian Society of Surgical Oncology, the Brazilian College of HPB, the Brazilian College of Surgeons, as we call it, CBC, some surgical students associations, in the support of the hospital we've been working for the last 21 years, Hospital Angelina Carol. Thank you very much indeed for you all, and especially for the speakers who are with us tonight. So I would like to formally introduce you all the speakers who are with us tonight. The first one, very close friend, someone that I like everybody very much, but Professor Silvania Pimentel from Curitiba. She's a former Mayo Clinic surgical fellow, board certified, very tough to do so. Professor at Hospital das Clínicas in Curitiba, and also surgeon, top surgeon, master surgeon at HT Trauma Center in Curitiba. Thank you very much for being here, and welcome at the HPB 21, Silvania.
Thank you, João. Thank you. Your very nice words. You are the guy, not me. Thank you. I'm very glad I'm here. Thank you.
Thank you. At the same time, I'm very honored to have Professor Eduardo Ramos, who's someone that I know for a very, very long time, since the time I met his brother, and the next year he was with us at the university, and then he switched to the federal one. I still remember the story. He said, my brother is very tough, and he was right. So after that, after very brilliant university, he was also a former Mayo Clinic surgical fellow in transplantation, HPB surgery. And when he came back to Brazil, he's developing even since then a very fine job on the HPB surgery, on all sorts of it, especially on pancreatic neoplasm most recently. Be welcome here. It's a pleasure to have you here tonight, Professor Ramos.
Thank you, João. It's a pleasure to be here and learn with all of you guys. And it's a special pleasure because I remember when João was starting his service in Angelina Carol. That was before I went to the States. And I went to see him and I saw his ICU. And I thought, my God, he has an ICU just for transplant patients. That was like a motivation for us. And then 5 years later, when I start back, it's very good to see someone ahead of you, because then you have a line to follow. And congratulations, João, for all of this effort in this meeting. And it's a pleasure to be all of you guys. Thank you.
Thank you. Thank you all. And the lecture tonight is going to be about neuroendocrine pancreatic tumors. And it's going to be presented by Professor Gaujoux, Sébastien Gaujoux, from Pitié Hospital, Paris, France. Professor Gaujoux is probably one of the world's most important authorities on the field. And I have the pleasure, we have the pleasure to have him with us tonight. And if you allow me to say some words in French, Monsieur Gaujoux,
Oui.
Merci énormément pour votre présence ici. C'est une satisfaction énorme de vous avoir, et pour la présentation, je suis certain que ça va être superbe. Monsieur Gaujoux, it's a pleasure to have you here tonight, and I'm certain that your presentation is going to be awesome, as your job is performed at Pitié Hospital. Merci énormément pour être là, et je vous souhaite une présentation superbe. I wish you a very nice presentation, an outstanding as the outstanding job that you perform at Pitié-Salpêtrière Hospital. Thank you very much, and be welcome here at HPB 21.
Thank you, my friends. Thank you, all of you. And I would like really to thank you, Dr. Nicolosi, for the invitation and all the organizing committee. I'm very glad and very proud to be with you tonight. It's very well and clearly very well organized. I'm sure we're going to have a great time all together. So as you can see, my talk will be on the surgical management of pancreatic neuroendocrine tumors and what you really need to know in your practice. First, clearly, we're going to focus on the surgical management of these pancreatic neuroendocrine tumors, and we will not study or we will not discuss of the management of a metastatic one. Otherwise, it's going to be a too large field, and we will focus on mainly primary tumor, secreting one, non-secreting one, genetic one, not genetic one, and that's already a very large field of study. So first, what you need to know on the epidemiology of those lesions. Clearly, they are very incidence. Clearly, it's about one new case by 100,000 inhabitants a year, and that's only represent 1 to 5% of pancreatic neoplasm. So clearly, if you consider Brazil, which is about 210 million inhabitants, it's only about or just more than 2,000 new cases a year. So that's very, very few for a large country as yours. But you need also to consider that those patients have a very good prognosis. And even if there is a low incidence, there is a very high prevalence because those patients can live a very, very long time. And most of pancreatic surgeons will have to deal at some point with their tumor. And clearly, if you compare pancreatic neuroendocrine tumors to pancreatic ductal when you look at the 5 years overall survival for localized tumor, it's as good as 94% for the pancreatic neuroendocrine tumor and only 34% for pancreatic ductal adenocarcinoma. And clearly, when you look at all stage combined, clearly more than half of patients with PNETs will survive compared to less than 10% with patients with pancreatic ductal adenocarcinoma. So clearly, those patients, you will see them in your clinic and you will have at some point to operate on them. But the big issue when dealing with the surgical management of pancreatic neuroendocrine tumor is that those lesions are highly heterogeneous. They can have various size. For some of them, they can like just size few millimeters, but the bigger one can be as big as 15 or 20 centimeters. They can be functioning and secreting a lot of various peptides, such as insulinoma, gastrinoma, vipoma, and so and so. But a lot of them, and maybe most of them nowadays, are non-functioning tumors. And lastly, they can be from a sporadic origin for most of them, but they can also be from a genetic origin, mainly multiple endocrine neoplasm type 1. So according to the aggressiveness of those patients, you will observe the benign lesion, but you would need to resect the malignant one. And you have a selective surgical or medical approach according to this supposed aggressiveness. And that is a big issue because tumor behavior is very difficult to predict as first sight. And we will see how to deal with that later. So clearly, when you are dealing with those patients and you need to take a surgical decision, you need to know if there is symptoms as presentation, mainly abdominal pain. Is it a secreting tumors? And which peptide is it secreting? Is there a genetic origin? Is it a MEN1 patient? What is the tumor locations? What is its size? What is its relation with the main pancreatic duct? What is the tumor grade? Is the patient fit for surgery? And is it fit for Whipple? Is it a progressive disease over time? Is it a metastatic disease? And if yes, is it metastatic only in the nodes, only in the liver, or is it a liver predominant metastatic disease? And is it a positive receptors on scintigraphy? That's also the last question that you should ask yourself. So how can you learn all? You can learn them for various clinicians. You can learn them for endocrinologists, from geneticians, from radiologists, endoscopists, pathologists, surgeon, anesthesists, and nuclear medicines radiology. So clearly that need a multidisciplinary team management. You can't not deal alone with patients with pancreatic neuroendocrine tumors. And if you want to have a good diagnosis, a good management, this management multidisciplinary. And I think dealing with those patients, that is clearly keys and highly important. When you consider now the treatment options, there is various therapeutic actions that can, of course, be surgery, and we will later focus on that. But you can also use somatostatin analogs, targeted therapy. You can use chemotherapy, interventional radiology and scleroscopy, or peptide receptor radionuclide scintigraphy. And you will use those various treatment options according to tumor aggressiveness that you can assess by tumor grade, which include Ki-67, mitotic index, and tumor differentiation. You can also assess by tumor progressions, by the presence of mets and especially bone mets, by liver involvement over 50%, by the general status of the patients, and by the somatostatin receptor scintigraphy and the PET-FDG uptake. All those factors will help you at the end to assess the tumor aggressiveness. But when we consider surgery, we need to acknowledge that there is up to now no single randomized controlled trial that has been performed on the surgical treatment of the PIDNET. So clearly, the quality of our knowledge remain low, especially compared to our patients that might have chemo or targeted therapy. So at the first question, for the surgery, when and how should it be performed? Clearly, surgery should always be considered, of course, within a multidisciplinary tumor board when you're dealing with pancreatic neuroendocrine tumor. Why? Clearly, because, and that has been proven, it's improved overall survival in almost all patients. Those are an article from the SEERS North American databases. Of course, you can see that when you are resecting the primary and the metastatic disease, you have an improved prognosis when you compare to no resection. But in metastatic patients, when you are resecting the primary only or the metastasis only, you also improving the diagnostic, the prognosis. So clearly, surgery should always be discussed within a dedicated tumor board. Of course, I didn't say that you should operate on all patients. And clearly, there is pancreatic neuroendocrine tumor that should not be operated. Those patients are quite easy to pick. They are the one with technical contraindications. They are usual, such as huge cavernoma, massive liver involvement. There is, of course, patients with poor or very poor general status, and those patients are not fit to have a Whipple procedure. There is patient with extrahepatic metastasis, and especially bone metastasis. That is a poor prognostic factors, and those patients are for most of them, not living longer with a surgery. And after, there is also patients with very aggressive and sometimes poorly differentiated tumor that we call G3 tumors. Those patients must have chemo first, and surgery is for most of them useless. So clearly, for those patients, massive liver involvement, huge cavernoma, poor general status, you need to have a multidisciplinary, multimodal medical strategy within a dedicated tumor board. There is various therapeutic options for those patients that will not undergo surgery. I will, of course, not detail all those therapeutic alternatives, but just remember that there are several of them. I will also not detail should give specific therapy, but just remember that those most of algorithms are based on the WHO 2019 classification. And it's important to know this classification because it will clearly dictate for a lot of patients the good therapeutic option. And the WHO 2019 classification is based on tumor differentiation, mitotic rate, and Ki-67s. And according to those factors, you will have a net grade 1 tumors when patients have well-differentiated tumors with low mitotic rate and low Ki-67s. You will have G2 tumors for patients with intermediate mitotic rate and Ki-67. You will have net G3 tumors when the Ki-67 is above 20%. But when you have like poorly differentiated tumor, you will have neuroendocrine carcinoma when, and in those patients, Ki-67 is always above 20%. Just remember these WHO 2019 classifications. And this is a very convenient and very effective classification since it's classify and prognostic very accurately G1, G2, and G3 tumors. But in those patients that you are not going to operate, just remember, even if they are metastatic, this is not a pancreatic ductal adenocarcinoma. The life expectancy of those patients is long, even in those, very aggressive tumors. And remember that quality of life is key in the management of those patients that will last at least for several years. So that is one of the also important message I would like to give you tonight. Of course, there is patient that should not be operated. There are some patients and with pancreatic neuroendocrine tumor that might not be operated. And we're going to see them. The first of those patients or the first of those tumors at the pancreatic neuroendocrine tumor when they are like sporadic, non-functioning, when they are asymptomatic with a positive true diagnosis and where they are below 2 centimeters in size with grade 1. That means well-differentiated tumors with a Ki-67. We published several years ago, and this has been confirmed by several teams, that you can safely observe those patients. And why? Because when you observe them for several years, and sometimes more than a decade, what you see that for most of them, the tumors is not growing and is at the same size over the years. When they are growing very, very slowly. And in all those cases, during the surveillance periods, no distant or nodal metastases appear. So clearly, and we will see that more in detail, clearly observation is an option in those patients. And that is clearly an evolving paradigm in the management, and is now, we will see that also in more detail, is now becoming the standard of care. And we recently published this multicentric work when on more than several hundred patients, we can see that in those patients with non-functional pancreatic neuroendocrine tumors, the disease-free survival is excellent, above 90% at 5 years. But it's not 100%, and they still have, in those patients with a tumor below 2 centimeters in size, 10% of patients with a node positivities. That means 10% that will recur at some point of their observation or surveillance strategy. So clearly, you should remember something when you're dealing with those small, sporadic pancreatic neuroendocrine tumors. And that's, remember you, also branch duct IPMN, where also we at some point operate on most, even all those patients. But no, we know that for branch duct IPMN, the disease-specific survival is very high. And clearly, what is the main risk in those patients? It's over-treatments, since pancreatic surgery, as you know, unfortunately, all know, has sometimes poor results with a very high fistula risk, especially on a pancreatic neuroendocrine tumor that has a soft pancreas with non-dilated main pancreatic duct. So the first patient that might not be operated at the patients with non-functional asymptomatic sporadic lesion. What about the cystic pancreatic neuroendocrine tumors when they are below 2 centimeters in size? We also recently that we can have the same wait-and-see policy when those patients are below 2 centimeters in size and when there are symptomatics, because also the 5-year disease-specific survival is excellent in these patients. But remember that when you're dealing with non-functioning pancreatic neuroendocrine tumors, size matters, as I told you before. In fact, in non-functional PNETs, the risk of nodal positivity is increasing with the tumor size and remain about 10% in lesion below 2 centimeters in size, and that will free survival. So this is a consistent observation in various studies, but what are inconsistent are the conclusions of these authors. For some of them, this 10% risk of recurrence and nodal positivity justifies surgery for most or even all patients, and for some authors, most of them have to know this risk justifies observation for most of lesions. So if you consider observation, which size will be the most acceptable for the nodal positivity risk? Few articles say it's 1 centimeter, 1.7, 1.5. Clearly, the 2 centimeter cutoff is the one which is accepted by most of us and most of a scientific society. But when you consider the size of those lesions, you should also remember that there is a radiopathologic discrepancy in about 20% of cases, and lesion can be over or underestimated by the preoperative imaging. So you consider size, but you should also consider other risk factors when you're going to say, I'm going to observe or I'm going to operate on those patients. We recently published also this large European surgical retrospective series on those patients, and we were able to define a low-risk tumor subgroup. Those patients have a non-functional sporadic pancreatic neuroendocrine tumors below 2 centimeters in size, but more importantly, have no ductal dilatations, are not negative on imagings. So when you consider this subgroup of low-risk patients, clearly the disease-free survival is above and way above the 95% are 5 or even 10 years. So you consider those low-risk tumors, but when you're going to also define or set an observation strategy or surgery, you should also consider the patient general status and his age, or at least its physiologic age. You're not going to do Whipple procedures on a 92% patients with 2 centimeters neuroendocrine non-functioning pancreatic tumors, and the tumor locations, because you're not going to have the same strategy with tumor in the head of the pancreas, which will require a Whipple procedure, and the one in the tail, where you can perform very easily a laparoscopic pancreatectomy. So when you carefully look at the guidelines for NCCN, observations can be considered in selected cases. And when you consider the European Neuroendocrine Tumors Society recommendation, clearly for pancreatic neuroendocrine tumors, when they are non-functioning, below 2 centimeters in size, incidentally discovered, without radiological worrisome features, observations is also an option. So we see which tumor might not be operated. Those tumors are the sporadic, asymptomatic tumors when they are below 2 centimeters in size. For most of them, they are grade 1, and they also can be cystic or not, that won't alter the prognosis of those patients. Which other pancreatic neuroendocrine tumor might not be operated? Those are patients that have multiple endocrine neoplasia type 1, when they have non-functioning pancreatic tumors and when they are below 2 centimeters in size. So clearly the same as before, but from a genetic origins. We also, with the group des tumeurs endocrines, were able to show that when you consider the thorough observation of those patients, very few of them will increase their size. When you look at the watchful waiting strategy or surgery strategy, the overall and disease-free survival of those patients is identical, or at least not significantly different. But also remember that also in those MEN1 tumors, about 2 centimeters, about 10% of them will be metastatic, even if they are below 2 centimeters in size. So some of the peanut that might not be operated, that are the MEN1 gastrinoma, where they are like below 2 centimeters in size. Why can you just observe tumor? First, because PPI treat the secretory syndrome very easily. You might need very high dose of PPI, but the secretion is no more an issue in those patients. And that is new because before the PPI era, those patients were dying from gastric or digestive perforation. You don't want to operate on those patients because most of the time tumors are multiples. They also carry a very low metastatic risk for small tumors, and the biological cure is very rare after surgery, especially if you're doing just a lymphadenectomy with the duodenal excisions. And clearly, if you're not doing a Whipple, very few of those patients will be cured. But even if you're like observing those patients, just remember that gastrinoma remain a significant cause of death in those patients. So clearly, look very carefully at those patients and ask them to never forget their PPIs. Otherwise, they will suffer from severe diarrhea, hemorrhage, and digestive perforations. So we see the patient that we shouldn't operate on. We see the patient that we might not operate it. After, there is patient that must be operated. Who are they? That's quite easy. They are all other pancreatic neuroendocrine tumors. But when you consider those patients that need a surgery, you will ask perform a pancreas sparing surgery or standard pancreatectomy. The pancreas sparing surgery, there are central pancreatectomy and enucleations. They carry a high morbidity. They also carry, even if it's poorly known, a significant mortality. They have excellent functional results on the other side. But it's not an oncological surgery because you're only able, to pick few lymph nodes and not to perform a formal lymphadenectomy. On the other side, when you do a standard pancreatectomy, either a distal pancreatectomy or pancreaticoduodenectomy, we all know the significant mortality, the poor functional result, especially after Whipple, but that's an oncologic procedure when you can do a formal lymphadenectomy. Receive tumors that will clearly have a positive impact. So clearly, when you're going to choose between pancreas sparing surgery and standard pancreatectomy, the main factor will be the pancreatic neuroendocrine tumor biological behavior and aggressiveness. And clearly, for pancreatic neuroendocrine tumors, when they are non-functional, below 2 centimeters in size, if you decide to operate on those patients, pancreas sparing surgery can be a very good options, but when they are above 2 centimeters in size, the risk of nodal positivity is important and standard pancreatectomy as required. Excuse me, it was a long day and it's almost midnight in France. For later, you want to do pancreas sparing surgery. For sporadic gastrinoma, it might depend. And for other pancreatic neuroendocrine tumor, they are highly aggressive and with very frequent nodal metastasis, and you want to perform a standard pancreatectomy. A few words on sporadic insulinoma. As a surgeon, what you should know. You should know that those lesions are benign for most of them in above 90% of cases. They are sporadic for most of them in about 90% of cases. They are unique, small, intrapancreatic for most of them, and you can quite easily locate them by CT, EUS, or MRI. The mortality from the tumor is very low, or around 1%, and the cure rate is very important. The key procedure for insulinoma are enucleation that can be done also laparoscopically. And those patients, when you do a R0 or even a R1 resection, they have excellent disease-free survival, and for most of them, they will never recur. Are patients with MEN1 lesions, they recurred or at least developed new lesions, or the very, very rare patients with true invasive insulinoma with lymphovascular invasions and lymph node metastases. Those patients remain anyway quite rare. When you are dealing with sporadic insulinoma, the main issue is to have a preoperative or at least an intraoperative accurate location. In most of cases, with modern EUS and CT scan, you can have a preoperatively location. If it's not working, you can use ultrascan, but these have a very poor sensibility and specificity. You can use Dotatoc, but more recently, extended PET-CT that will be very specific for insulinoma. Lastly, you can have an intraoperative operation, but if you don't find the insulinoma, that might sometime or even rarely the case, you should not today do a blind distal pancreatectomy when you did not see the tumor locations. An example is here of a cystic pancreatic neuroendocrine tumor. You can see here the intraoperative view. You can see here the enucleation cavity at the end, and you can see here the pancreatic neuroendocrine tumors in a cystic form. But what will be the next step for sporadic insulinoma? The next step might be radiofrequency ablation for selected cases. That's an ongoing debate. In my opinion, I think that radiofrequency ablation is a very good alternative to surgery for tumor located in the head of the pancreas. Sorry, since we know that in those patients, the risk of pancreatectomy is much higher than the risk of radiofrequency ablations. But that's an ongoing question, and we will have, we hope, questions soon. Another tumors that you need to know are the sporadic gastrinoma. What is a sporadic gastrinoma? It is a tumor for most of them located in the duodenum, even if sometimes it can be in the tumors have for most of them a small time for 1 centimeter with 10 millimeter to 100 millimeters. They are often multiple and often malignant with the early development of not positivity. The main issue when you are dealing with those patients is to localize the lesions. It's very difficult because it's a small tumors and most of those or exam are not sensitive enough. So you need to do CT scan and MRI, fibroscopy, EUS, ultrascan and Doppler if you're not localizing accurately the lesions. But remember that most of gastrinoma are within the stability and passero triangle. And so don't look at the tail of the pancreas. Most even of all your gastrinoma should be in this triangle. What we know regarding sporadic gastrinoma, we know that resections increase survival. But despite early surgery from those patients, we know that cure is rare, and consequently recurrence is frequent, and as frequent as 60% of biologic recurrence at 2 years, or 40% of morphologic recurrence at 2 years. If we know that surgery improves the survival, we also know that lymphadenectomy increases the survival of those patients. On a technical and practical point of view, what you do, you should start with a surgical exploration with the palpation of all pancreas, intraoperative US, transillumination through a fibroscopy and duodenotomy. You should remove all suspicion lesions since those pancreatic neuroendocrine tumor are not very large, and you should do frozen sections if this is required. So clearly you can do duodenal location. For duodenal locations, just enucleation and lymphadenectomy. For pancreatic location, you can do either enucleation or lymphadenectomy, but pancreatic duodenectomy might be some of that very intolerant lesions. That an intraoperative view of a transilluminations. You can do palpation of the lesions. You can use EUS to look at your lesion within the pancreas, but also you can do at the end an extensive lymphadenectomy to improve the prognosis of those patients. Some of the lesions that you need to know, those are glucanoma, vipoma, somatostatinoma. Why you need to know them? You need to know them because they are frequently with node positive positive lymph node. They are like frequently metastatic, and for most of them, they carry symptoms, either because of the secreting nature of the lesions or because of its size. And you should, on those patients, do surgery and standard pancreatectomy as soon as you can and as frequently as possible. Another important point, should you do adjuvant or neoadjuvant treatment in those patients? The answer is clearly no. Neoadjuvant or adjuvant treatment is not indicating these subgroup populations. Last question as a surgeon, when you did a surgery on those questions, how you should follow them. You should follow them at least yearly by cross-sectional imaging and ideally MRI, because a CT scan will give them some additional radiations. Chromogranin A is not recommended, and scintigraphy receptor somatostatin remain controversial in the follow-up of those patients, and especially the non-functional one. So when you decide to follow them, this should be done according to the risk of recurrence. And some of our friends define this recurrence risk score, especially for non-functioning lesions. And if patients are asymptomatic, with a tumor size below 2 centimeters in size, with a K67 over 20% with a lymph node positivity, those patients and should be followed every 6 months. Some other have very poor risk, and observations within 2 months need to be enough for me. So if we want to conclude our talks, first, as a surgeon, we are far from evidence-based decision in surgery regarding pancreatic neuroendocrine tumors. But there is several international randomized controlled trials for the medical management of PNEDs, and consequently, we should be able at some point to recall them. In conclusion, when should you do surgery? Surgery is best indicated for NET grade 1 tumor with a small disease burden and a small aggressiveness of the. Clearly, for neuroendocrine carcinoma, there is no role for surgery. Surgery can also be omitted in small, in a Leticia room. And lastly, mostly no surgery for NET-G3, but for the other lesions, surgery should be discussed on a multidisciplinary tumor board, as I told you at the beginning of this talk. So, which are the other variables that should be taken into account as we previously said, the age of the patient, is it fit for surgery? The locations, is it in the head or in the body tail? What is the grade 1 of grade 3 of the lesions? What is the stage of the lesions? Is it an hereditary? And what is the functions of these lesions? When you have all those factors, you need to remember that pancreatic neuroendocrine tumors are highly heterogeneous tumors. So there is a need as a surgeon for a medical college of pancreatic neuroendocrine tumors, and there is also a need for dedicated patients. Surgery, remember, should always be discussed in order to improve prognosis, control symptoms, and prevent complications. But also remember that in selected patients, mainly and namely the non-functioning pancreatic neuroendocrine tumors, when they are below 2 centimeters, asymptomatic, a wait-and-see policy is a safe option in those lesions. And last, remember that God put the pancreas in the back because he didn't want surgeon messing with it. But just remember that some patients can be also safe from our complications. Thank you very much, my friends, for these invitations. And I'm very, very happy to answer, if I can, to your questions. Thank you. Yes.
Thank you so much, Professor Gaujoux. I hope I am pronouncing your name correctly. Gaujoux? I'm not good in French. Very, very nice talk. Even I could see that you were very tired. Your presentation was your presentation was perfect, and I love the way that you divide, the way that you explain, because it's a very complex issue. Even they are really very, very rare. You have many different treatments for each kind of PNETs. So I love the way that you present, the way that you divide the disease. And if Eduardo don't want to add anything now, I'd like to ask a question now. It's okay for you, Eduardo?
Go ahead, Silvania.
It's just about the lymphadenectomy for non-functional PNETs that you are going to perform on standard pancreatectomy for the large tumors. Do you think that for the non-functional, not gastrinomas, the lymphadenectomy matters for the survival or just for staging?
I think those patients can be cured, at least for the one with a few lymph nodes, and that's, I think, matters. And I will propose sometimes very aggressive lymphadenectomy in those patients. We know, and that at least for pancreatic ductal adenocarcinoma, extended lymphadenectomy will not improve the prognosis. Even if we don't really know for those lesions, I will push for an aggressive surgery because clearly that's the only way to cure them. But that's an opinion, and as I told you, the level of evidence in the management of those. But I will argue for aggressive lymphadenectomy in those patients.
Okay, thank you so much. And again, congratulations, your talk was very nice. Thank you.
Thank you very much.
Hi, Sebastian. I have a couple of questions. Since we have a lot of surgeons, watching you, I'm going to ask a couple of questions in a practical way, just to know the way that you guys manage those patients, just to help us, and to see ourselves if we are doing the same or doing something different. Example, the role of PET scan before the surgery. You guys are doing a lot of data before the surgery. And how about biopsy? When are you indicating the biopsy before surgery? And the role of PET scan and biopsy before surgery.
Alors, clearly, the octreal scan to help you for the but mainly we use DOTATOC now. But when you're dealing with somatostatin receptor scintigraphy, when you have an uptake of those lesions, they are most of the time well differentiated. So that might be a diagnostic tool because when it's positive for somatostatin receptor scintigraphy, you have a true diagnosis of PNETs, but that's also help you to define the differentiation of the lesions. When you're looking at those lesions on FDG PET scan, most of them will not have any uptake. But if there is some uptake, clearly those are aggressive lesions. So I think that nuclear medicine, scintigraphy, or PET-CT can be very useful to preoperatively assess, and especially for non-functioning tumor, the aggressiveness of the lesions. For the biopsy, at the same point also, when you need to tailor your management, either observations or surgery, but when you wonder, are you going to do a pancreas-sparing surgery or formal lymphadenectomy, having a pre-op biopsy might help you. And for example, if you assess, if you have a very high or at least a high K67, above 5%, you will do a formal resection. If it's below, clearly, I think that pancreas-sparing surgery will help you. So clearly, if you can get information before surgery on the aggressiveness of those lesions, and as you said, biopsy, scintigraphy, or PET-CT will help you, it's always good to tailor your surgery.
We have a problem with data here, because usually the insurance companies, they don't pay before you have a histological proof that you have a neuroendocrine tumor. And this is sometimes a problem, and I like sometimes to help to plan the surgery, like you said, but sometimes it's difficult to have the CT before surgery. And since below 2 centimeters, usually we don't operate those patients. The question is, when you indicate surgery for patients with lesions for 1.5, okay, and the no, I'm not talking about insulinoma, in a non-productive neuroendocrine tumor, below 1.5, is any role for surgery?
It's really difficult to say, because showed you the follow-up of the patients is always below 10 years. So clearly, on the scientific point of view, we don't know what will happen after 10 years. So if it's a 75-year-old fat man with 1.5 centimeters lesion in the head of the pancreas, I will observe those patients. If it's a 1.5 centimeters lesions, it's in a fit and young 35 man in the tail of the pancreas, for sure, I will go for a lab distal. So clearly it depends on the age of the patients, of the situation of the tumors. And when you don't really know, I do a DOTATOC and a PET-CT. If there is any uptake of the PET-CT, I'd go for surgery. And if there is no uptake on PET-CT and a true uptake on a DOTATOC, I would go for observation. So clearly, I try to have as much information as I can before surgery for those difficult cases.
And how about liver resections? There isn't a number of liver mets that you go simultaneously, the pancreas and the liver, or how aggressive you go to the liver?
How aggressive I'm going to the liver? that's difficult too, because in the 90s or the beginning of the 2000s, we had very, very few alternatives to surgery. And basically surgery was done for most of them. Nowadays, we know that when we do surgery, most or even all those patients will recur. We know also that when you look and when you see 10 lesions on your pre-op examinations, there is 25 of them anyway all recurs. If it's a very young patient with distal lesions in the tail of the pancreas, with very few liver mets, I will, I think, go for distal pancreatectomy and a total clearance if it's doable of the liver, but mainly with also a parenchyma sparing strategy. I will not go for major hepatectomy in those patients. And I will not go for Whipple in those patients. I will not go for Whipple because after you won't be able to do safely radiofrequency ablations because of the hepaticojejunostomy, or you will not be able to do chemoembolization either because that. But on the distal one, if you can clear the primary lesions, if you can have a liver mets only disease in very young and highly selected patients, you can sometimes offer them a liver transplant at the end. So it's a different question. I think we are moving slowly to less surgery because we have also more efficient medical treatment nowadays.
Then my last question, for example, and if you have a patient with dozens of liver lesions and has a primary tumor in the body or tail of the pancreas. Okay,
sorry, I didn't hear you because of the connection. Can you repeat the question, please?
Sure. Neuroendocrine tumor in the body or tail with dozens of many mets in the liver. When is the best time to resect the primary tumor? You know what I mean? I'm talking about a G1 or G2.
I will, I think, do initial full body assessment to be sure that it's going to be a liver-only disease. I will put those patients on either analogs or like chemotherapy or targeted therapy for at least 6 months or a year. If after a year there is no tumor progressions, I will go for surgery. Maybe wait an extra years because the patient selection is very tough in those patients, and I will possibly propose those patients at the end for liver transplants. But we should also keep in mind that patients with dozens of liver mets can live sometimes with only somatostatin analogs without any progression for 5 or 7 years. And when you introduce after ablations, chemoembolizations, targeted therapy, chemotherapy, PPRTs, those patients can live for 15 years with treatments. And if you transplant them, you also can, like kill them postoperatively or give more quality of life because of the transplants. And I think that quality of life should be like in our mind when we are dealing with those patients.
Perfect. I'll let João and Silvania have more questions. I can spend 1 more hour discussing here, but let's listen to everybody else. Good presentation. Thank you. And your last slide was about how to follow those patients with that score. That's a nice one. I'm gonna start to follow that.
Thank you for your questions.
No, I don't have any questions anymore. Thank you.
Yeah, I just I had a question, but I think you quite answered it. It was the criteria for liver transplantation in most of those cases, because as you said, sometimes it's pretty tough because sometimes you can live longer without a liver transplantation. So I think it's probably one of the most difficult indications because you have a patient that can be very long, and at the same time, and it's tough to indicate transplantation for those patients. You see sometimes the liver come with plenty of lesions, but this patient can last very long time. So, and we know at the same time that sometimes from some previous papers that those patients, although they have a disease that's not considered so aggressive, as you said in the very beginning of your presentation, once they are transplanted, the 5-year survival of the group transplant is not that good as we expected. So finally, which are the ones that are finally indicated through transplantation, in your point of view?
That's very difficult because, as you say, there is a shortage of transplants. Those patients can live forever without sometimes any treatments. What we know is when you are doing liver transplants at the end of the disease, when you need a very large surgery to take off the primary, where you have a huge liver, those patients are doing poorly, even post-operatively. So you should not transplant them at the very end of the disease. But before, when you should do it, at the beginning, after a few years of selections, clearly I don't really know. What I can tell you is over the last 15 years, the number of transplants for pancreatic neuroendocrine tumors clearly decreased. And I will say, sometimes discuss that in our tumor board, but rarely, or I would say even exceptionally, we will perform it. So I don't have true answer for that. Really, it's really on a case by case discussion. But that's a very smart and difficult question to answer.
Sure, yeah, certainly. In the another question, because you one of your final slides, you said that the future treatment is going to be radiofrequency for small pancreas tumors, as we do for small tumors in the liver as well. Have you already started this? Do you have an experience at Pitié-Salpêtrière with this kind of treatment, or are you still expecting some new papers to start your own?
I think for insulinoma in the head of the pancreas as an alternative for Whipple procedures, that's very, very good alternatives, because, like doing a Whipples for benign tumors in a soft pancreas in a 75-year-old woman, like with a small main pancreatic duct. I mean, sometimes you can kill those patients for benign tumors. So clearly, that's a good option.
Sure.
We only have, the published patients, they're like less than 100. So we don't really know the exact morbidity of the procedures. And for sure, we will see also some like dangerous and terrible acute pancreatitis post ablations. When it's in the tail, clearly, I prefer to do a lab distal than dose surgery. That is for insulinoma, and I think that's fine. But the big issue is that endoscopy are soon going to move from insulinoma to a small non-functioning pancreatic neuroendocrine tumor. And that's going to be crazy, because the issue in those patients is not the size of the lesions, it's not its secretions, is the risk of nodal metastasis. And this risk is not going to disappear by destructing or like making the size of those lesions be smaller. So clearly, we should avoid radiofrequency on those small non-functioning pancreatic neuroendocrine tumor. But the big issue is that quite a lot of those patients are seen by gastroenterologists first, and they don't refer them to a surgeon, and are going to refer them to endoscopist. And as surgeon, we should be very careful of that. Insulinoma in the head, very good indications. For the other localizations and other lesions, I will say no, because we don't have any follow-up of those procedures up to now.
Very interesting. Very interesting. It's 1 a.m. in France. Does anybody have a final question? Because Professor Gaujoux has another conference tomorrow morning. He's in a hotel right now, actually. Eduardo, Silvania, do you have any question? Any final question for him?
I have a last question about the nanoknife. Do you know that nanoknife, they are talking about like electroporation of the tumor, and you guys have any experience, and to have your thoughts about it?
With the electroporations, no, I don't have any experience on a personal point of view. Even in France, there is only one center performing electroporations, and it didn't really publish its results. We are of course aware of the several publications that has been performed in pancreatic ductal adenocarcinoma in some American and New York teams. That seems to be interesting because it's a non-thermal ablations that does not destruct the protein, and that might also increase the immunogenic answers after destructions. But within the specific scope of neuroendocrine tumors, even if it seems on at least intellectually a promising tool, I don't have any clue of the interest of those. But I think we should look at it carefully. Do you have some experience too with irreversible electroporations?
No, zero. And I'm not believing a lot, but let's see. Like you said, you need to pay attention.
Yeah,
to results.
You should pay attention too, but clearly it might be dangerous, also because like putting some electrodes in it, and even if I say that intellectually it's very smart, even when I was thinking at some point to start a prospective trial on pancreatic ductal adenocarcinoma, but you should never know when you need to do that, because it shouldn't be an alternative to surgery. You have also the radiotherapy, the gamma knife with the FOLFIRINOX. So I don't really know when you should use it in the management of those patients, even if it's intellectually having a non-thermal, irreversible electroporations seems smart.
I agree, and good lecture. Thank you, Sebastián. Thank you.
Thank you very much.
Okay, so I think that we're probably finally going to have your time deserved for a rest. Sorry for disturbing you so late in the night.
It was my pleasure to be with you.
And so I would finally, before closing this lecture, just would like to thank you very much indeed for this outstanding presentation of such difficult subject as the neuroendocrine tumors of the pancreas. Something that we see so rarely, and that at the same time it's very tough to manage them so well and so in such a fine way that, like you did in a reference center as the Pitié-Salpêtrière. Thank you very much for so many information. Thank you very much for your time and to be with us tonight, and for your kindness as well. Hope to see you in Paris pretty soon.
You're always welcome, and be my guest in Paris as soon as you can.
Yes, as we can, yes. And thank you very much indeed as well for the speakers, Professor Ramos and Silvania Pimentel, some close friends, very fine surgeons, and people who study a lot and keep the level of pancreatic surgeons very high here in the city and in our surgical community. So thank you very much indeed for all people who've been with us attending the course, and thank you very much once again. So I think that's it. Thank you very much. Have a good night, Sebastián.
And
you all.
Thank you.
Bye. See you guys.
Thank you.
See you next time.
Thank
bye
you.
bye.
Congratulations.
Bye.
Thank you.
Thank you so much.
Congrats.